Welcome to the third module for your Nursing for Authority course. This module and the last module contain lots of elements that have come from your fundamentals course, as well as a few basic med-surg concepts. So I'm not going to spend a lot of time re-educating you on those topics. More like I'm just going to remind you the things to really focus on. And then we'll talk a little bit about quality in the last few slides. The first area we're going to talk about are infection control concepts. These are throwbacks to your fundamentals. What's important for you to know from an ATI standpoint, from an NCLEX standpoint, and from our testing standpoint is understanding which precaution goes with what type of PPE. So looking at the, having an idea of the general diagnoses that lead to which precautions, and then being able to understand what type of personal protective equipment is required for each of those types of infection control precautions. This is a concept that is going to be heavily covered on NCLEX and ATI, so you want to be re-familiar with it. Your ATI book does a pretty good job of just doing a general overview, but I do want you to be able to connect the diagnoses with the type of precautions. Another concept that is focused on in this module are hazardous materials. And the key concept for hazardous materials is understanding that there is a standard that's issued through Occupational Safety and the Health Administration, which is OSHA, and they drive how we handle hazardous materials. They also give us information about how we can handle hazardous materials within a healthcare situation or a healthcare organization. The goal of OSHA is to make sure that we have safe working environments and that we have the equipment we need so that we can function safely. The other aspect of managing hazardous materials is making sure that we have a hazmat response team or a committee that's assigned to make sure that we have standard precautions that drive our practices and how we respond to hazardous materials. So OSHA is kind of the starting point for gathering those policies and procedures for organizations. And then within the organization, there should be a hazardous material or a hazmat response team or committee that helps carry those processes out and maybe individualizes them on the department that they're specific to. You know, again, the goal is making sure that all of the healthcare team is working in a safe environment and that we have the equipment we need. Followed up with that is looking at basic safe equipment use. And when we talk about equipment, we're talking about the things, the tools that we use to provide care in the healthcare environment. So down to your sphygmometer, to your IV pumps, to your SCDs in the bed, our actual bed. Many of them are motorized and have computer components. All of that is equipment, and we have to know first and foremost that we've been trained on each piece of equipment that we've been provided, and that after that training we're competent. So I don't think it is uncommon for folks to go to training seminars and walk out and go, well, you know, I still don't have a clue what I'm doing. We're not just required to be trained. We're required to be trained for competence. So when you walk away from an in-service on a new Alaris pump or IV pump, can you go back in and repeat the steps that were provided through that training? So we want to be sure that we are competent. An employer perspective needs to really focus on a process for safety monitoring. How does your employer or the healthcare organization make sure that there are kind of safety checks that help guide safety monitoring? And then, of course, we're looking at the basic safe use. Most of the safety issues with equipment kind of come into two buckets. One is, do I know how to use it? So safe use. And then, do I know how to manage the power supplies that go with safe use? So if you've been trained and you're competent and you know how to use the piece of equipment well, then do you know how to maintain the power source? You know, the silly things like when we're not using a piece of equipment, is it unplugged? When we're plugging it in, is it being plugged into a grounded electrical socket? Are we making sure that we keep our emergency equipment plugged in to the right power source within a hospital system that's attached to a generator? So many hospitals have live electrical sockets that are specific for emergency equipment. So if you do not plug in your emergency equipment into the proper electrical socket, then in the event of a power outage, you could wind up losing valuable and vital equipment. And the old-fashioned reminders of don't use an extension cord in a healthcare setting. Period. Everything needs to be plugged into all medical equipment needs to be plugged into a wall socket that is properly grounded. And if you're like me, you're thinking, okay, I'm not an electrician. Why do I need to know all of this? Well, we spend a lot of time bending over, pushing and pulling things and plugging them into the wall. So we do need the basics of how we handle the power source for our equipment. One of the tried and true areas that again go back to your fundamental days are accident and injury prevention. I've thrown up a few key concepts that come from your ATI book that deal with falls, seizures, seclusion and restraints, and fire safety. When you think about falls, I want you to be focusing on who's vulnerable to falling, and unfortunately, elderly tend to be our predominant folks who, if they fall, are severely injured. So we really want to look at focusing on preventing falls for our elderly clients. Seizures, the highlight area is maintaining their airway, and then injury prevention while they're having a seizure. And add a caveat to that is comfort measures. Seizures are extremely scary for people. Even if they have a seizure disorder, they wake up and they're disoriented. They could be embarrassed because they've lost control of bowel and bladder function. So not only do we want to make sure that during the seizure that their airway is clear, that they don't have restrictive clothing, and preventing them from injury, that they are not bumping up against the headboard or a wall or on the floor, choking hazards, that we're not putting anything in their mouth to prevent biting down that can actually cause more injury. But we've got to think about the psychosocial impact of what having a seizure does to the client. So we've got to add some emotional component to that to support them. The seclusion and restraints, the biggest suggestion I have for you is, from a safety and proper use standpoint, is know what your organization's policies and procedures are and follow them. Period. They're going to vary state to state, and they're going to vary depending on the patient population you're going to be using. Remember that before you use either of those interventions, you need to know what your policies and procedures are, and be very aware of the risk. We talked about this a few modules ago about false imprisonment and injury. So know the reason we're using them and the how we're using them to make sure that we're protecting the patients, not just physically, but legally, practice-wise. Fire safety, it's the good old race and pass mnemonics, and then to know what the types of extinguishers are, and those are the class A, B, or C. I will tell you, I have been doing fire safety training I've been a nurse, I guess, almost 26 years this year, and I still have to look up which class fire extinguisher I have to use. I'm so glad now that when they are labeled as class A, B, and C, they actually tell you what A, B, and C make, what that matters, or what it means. So brush up on those things, because again, these are the basics. So you're going to see them on ATI, you're going to see them on NCLEX, and you'll see bits and pieces of this on our quizzes. Home safety, the focus is on developmental risks. I'm not going to go on each of these by the age group. Your ATI book breaks them down fairly well. One of the things you're going to find is there's some crossover between age groups, and that's just real people. And you can find, these are done in broad strokes. So refamiliarize yourself with developmental risks when we think about home safety for the purposes of this slide. I will tell you, again, this is one of those things that NCLEX loves, ATI loves. From a leadership standpoint, I'm not overly interested in it, but your book is. So brush up on these. You are going to see this on ATI for our course, and you'll see it on our quiz. Basics in home safety, I want you to review these. Your ATI has a paragraph for each of these. So much of this is just common sense, and so much of this is things that we talk almost conversationally about. So I want you to brush up on those, just to be reminded that these are included when we teach our patients who are going home or have home issues. These are the areas that we're going to make sure we don't have safety risks for them. Ergonomics, this is the safety for you. This is reminding you that when you're picking up heavy equipment, when you're moving a patient, when you're pushing a bed down the hall, are you making sure that you're using the proper center of gravity? Are you lifting with your legs? Are you pushing versus pulling, and which one is appropriate? Again, this is one of those basic concepts. Just want to remind you that it's still out there and it could show up on the ATI tests as well as NCLEX. Again, I have absolutely no idea how this relates to leadership, but ATI seems to think so. So here we are. All right, let's shift gears a little bit. Let's talk about quality control. This is an area that actually relates to leadership, and it is a key role for our nurse leaders, even our bedside nurse leaders, the folks that are just providing care, not just providing care. Providing care. Everything we do is important. We're responsible, first and foremost, we're the frontline defense for quality. So I'm going to give you some key concepts just to tie back into your reading with Marquise and Houston. Defining quality healthcare, the Institute of Medicine does a great job of that, and it reminds us how important quality is for our patients. We know that there's a quality gap, and a quality gap is defined as the difference in performance between a top performing healthcare organization and a national average, and that's called the quality gap. So it's whatever the average performance is to the very best performance, and the goal should always be to be stretching and growing towards the top performers. We don't want to be at the benchmark of average. We want to be growing. When we think about this being a new section of focus for the role of a leader, this is called a controlling measure. And when we are properly assessing quality, we can address the gaps that occur within our own organization. Quality control should not be implemented solely based on when there's a problem. We should not be dealing with a hospital-acquired infection when it happens. We need to have processes and policies in place that actually prevent quality issues. So we don't want to always be reacting to it. That's not quality control, that's damage control. We want to be looking really at how do we anticipate problems, how do we prevent problems, and how do we put steps in place that protect our patients and give them the best potential for quality outcomes. There are three widely accepted steps for a quality control process. And the first is to determine what your standard is. Where are you headed? Where do you want to go? So what that would be the standard you want to meet. Then you're going to gather information to determine whether the standard is being met. So are you meeting the standard? And then you're going to create education or corrective action to take if we're not meeting the standard. So we have to decide what the standard is going to be. Then we've got to figure out if we're meeting the standard, and then we've got to figure out how we're going to grow. Quality control it really involves the activities of evaluating, monitoring, and regulating our services that we render to the patient. So those are the elements of that. Although the organization has to be realistic about the economics of providing care, nurses really do have the heart of excellence, and we are always looking to drive quality. And when we're driving quality, we need to be pushing for optimal levels of quality care rather than minimally acceptable levels. And what we know is that optimal levels of care cost money, and they require resources. And that is where we struggle with defining what the standard is. Because if we define the standard to be the top performing organization, if we benchmark with them, then the cost of that excellence is going to be much more than if we decided that our standard or our benchmark that we were measuring towards was the national average. So we really have to figure out what our own drivers for excellence look like. I want to remind you that quality control, when it's done well, is integrated across an organization. This is not something that happens in the executive level of nursing directors and nursing executives. This happens through every layer of leadership within the organization and should drive down to the nurse-patient relationship. If we're doing quality well and we're doing it the way we should, then we're involving everybody at every level, and we're all talking the same language, and we're sharing a goal that we plan to accomplish. The next concept I want to share with you is benchmarking. And benchmarking comes in the steps of figuring out what our criteria want to be, what our criteria should be. And very often we look at what the best performers are doing. So benchmarking is the process of measuring products or practices or service against the best performing organizations. So if I'm going to benchmark my hospital's catheter associated infections to another organization, then I'm going to go to the Mayo Clinic, who has one of the best infection control processes in place and has the lowest infection control numbers in that specific area, and they're going to be my benchmark. Think about it as a pace car. They are the top performers, and our benchmark is to try to get where they are. The bottom of the benchmark is always the national average. And between that national average and those top performers, that was what I was just talking about being the quality gap. Our benchmark should be excellence. Our benchmark should be the best we can be. And understand that can be pretty aggressive depending on where you're starting out. Organizations can determine how and why their organization differs from the benchmark, and then they can use that benchmark as a role model to drive performance. If I'm in a small community hospital and I'm a level 3 trauma center, me benchmarking my standards against a level 1 trauma center in an urban area that's 3 times as big as me doesn't make sense. So when I benchmark, I should really be benchmarking within an organization within similar size and similar levels of acuity, because it gives you an apple and apple comparison, and you want it to be a fair comparison. So just want to plug that concept in there. When we look at standards, this is how we figure out where we start our benchmark. It's the first step in an effective quality control program. We figure out what our standards are, and we need to know what the predetermined level of excellence that serves as a guide for our practice. It's got to be objective, measurable, and achievable. There's no one set of standards that fits every organization. We can't say that this number of readmissions into our emergency room based on COPD is an acceptable number, and that number would be 10 in a rural small community-based hospital, and that 10 numbers still make sense when you look at 1,000-bed urban level 1 acute trauma center. So you've got to make sure that the standard that you're choosing fits the organization. We also want to understand the American Nursing Association has a role to play in the standards of professionalism. We'll talk about that in just a few moments about the ANA. The ANA drives our quality, and it sets the standard for how we provide care. And I'll plug that in just another moment. Again, just to remind you, the first step in a quality control program is you've got to figure out what your standards are. Where am I going? What's my goal? One of the other concepts that's out there are clinical practice guidelines. And clinical practice guidelines become a standardized way that drive patient care. The goal of a clinical practice guideline is to improve quality while saving money. It is a physician-driven process. These can also be called standardized clinical guidelines. Folks, one of the biggest elements of this is that they need to be evidence-based. So they need to be driven by what current best practice is and what current evidence says is best practice. They should be on the cutting edge. We have a great free resource, the National Guideline Clearinghouse, the NGC. It's a free public resource for evidence-based clinical practice guidelines. It does a great job. It is sponsored by the Agency for Healthcare Research and Quality. And it has a partnership with the American Medical Association and the American Association of Health Plans. They do a great job of providing these free guidelines, and many of them have been integrated into electronic medical records. So knowing that the National Guideline Clearinghouse out there is a really good resource. We want to remind you that nursing research should be used to help drive evidence-based practice. So when we talk about evidence-based practice, while the clinical practice guidelines are a physician model, we need to make sure that the nursing voice that's influencing these practice guidelines that includes nursing care are supported by nursing research and best practice. So we want to make sure that nurses are staying abreast of current research, and that we're given the resources that we need to be good nurse researchers, that we're given paid time off so that we can do research, we can use, that we're given proper resources and mentoring so that we can be successful researchers, so that we can kind of feed into the stream of evidence-based practice that is then driving the clinical practice guidelines. So if we have a standard and we are working towards a specific standard, there are ways that we audit this process, that we think, okay, how are we doing? And these are the three ways. Audits are basically an official examination of data. We can do it retrospectively, so looking backward, we can look at concurrent as it's happening, and then prospective of what we think will happen in the future. Structured quality audits look at the relationship between quality care and an organizational structure. So the organizational structure really is looking at resources. So how does quality care relate to staffing ratios? How does quality care relate to staffing mixes or wait time or the use of the electronic medical record? So these are standard structures within an organization. The next one is process. So this looks at quality outcomes based on the process and how things are being done. Typically the process is task oriented. How does quality look when we follow a certain protocol? What does quality look like if we follow medication reconciliation? And then we have outcomes audits, which is the best and most specific measurement of the nursing intervention's influence on a specific outcome. It is the most accurate way to measure nursing quality, because we know that our interventions within the nursing process, that our interventions are then evaluated for the outcome. Did what I plan and then do result in the outcome I expected? It's defined by the end result in care. So how did the patient's health status change based on what I did? Now, while we know that the outcomes audit is as accurate, it's the most likely to create a relationship between the intervention and the clinical outcome, I want to just add that it should not be the only criterion we use for quality measurements, because you're waiting for something to happen and to know whether you've met a goal or not until the end point. We need to always be looking at our quality process throughout the process of providing care. So while it's a great tool, we need to make sure it's not the only tool. And the last thing I want to touch on, as I said a few moments ago, is the American Nursing Association Scope and Standards of Practice. This is in the highlight is in your textbook, so make sure that you read through them. I want you to be thinking about the purpose of them. So the ANA Scope and Standards provide a broad set of objective guidelines that are the foundation to guide and measure quality nursing care. Fortunately for us, nurses wrote our standards, and we're nurses and we appreciate this. They follow the nursing process. So the assessment, diagnosis, outcome planning, implementation, and the evaluation is how they're laid out. There are 6. They're very relatable. So I want to remind you that they're out there and that we are held as nurses to use these as the foundation for our nursing practice. This is our underpinning. We should always be following the nursing process, and that aligns with these scope and standards. So I do want you to take a look at those. ATI, NCLEX, I know specifically, loves to talk about the scope and standards, and the reason they talk about them is not because it's an arbitrary tool. It is an integrated guide for nursing practice. So I want you to be familiar with them. I want you to know that they follow the nursing process, and they really are an objective driver for our quality of care. Okay, folks, that is it for this Module 3 for this chapter in ATI. If you have questions or concerns, please touch base and let me know. Take care.